Your last day, how nice. Okay, so yesterday we were talking about cardiogenic shock, and we had gotten to the point we were discussing the collaborative care. So collaborative care, the goal here, remember your shock state. So what we're trying to do is restore blood flow because we want to restore balance between the oxygen supply and the demand from the heart. And the heart's in trouble and the body still needs what it needs. So we have to restore that. So we can do the cardiac cath, get up there quick. We could do stenting while we're in there. We could do revascularization if you can't get to PCI. They can do the clot busters. And if it's your valves involved, they're going to rush you and see if they can't replace your valve. Okay, so what else? Support the stroke volume and the cardiac output. This is important, right? This is hemodynamic management. So right off the bat, you may see someone in the ICU, throw them into Trendelenburg. Fluid resuscitation, it's okay if we know what we're dealing with. If the heart cannot pump this out, we're throwing the patient in worse failure. So they wait and see what it is we're dealing with and see if this is wise to give them fluid bolus. Oxygen, ventilatory support, of course, by this point they're starting a code situation. We want to reduce preload, so everything coming into the heart to get pumped, we want to reduce that pressure coming into the heart because the heart's in trouble. We want to reduce the afterload. All the resistance the heart has to overcome to get blood out of the heart, we have to reduce that pressure because the heart isn't strong enough to deal with it. And we want to reduce the heart rate so that when the heart pumps, it's had a chance to fill the best it can and it can maximize what it's getting out. Okay, what do we do with that? Well, we give nitrates, so they give nitroglycerin. Now again, this is going to drop the BP. This could make your patient seem like hypovolemic because you're dilating all the vessels, so they drop their BP. So we're very controlled with that. If we think they have too much fluid on board, they can give them diuretics, get rid of some of that fluid, and we can give beta blockers because it will control the beta response from the adrenal glands, and it will reduce the heart rate and allow us some vasodilation of vessels, reduce the BP. So I keep talking about the intra-aortic balloon pump. I keep measuring it, and it's coming up, I promise. But that's another thing we can do. When the left ventricle is failing, they can put in an IABP, and it really essentially tries to maximize what's in the ventricle and what comes out. It's like having your own little left ventricle out on your left arm, so to speak. I'll talk about it in a minute. It can be the ventricular assist device I talk about, that people have LVADs or RVADs or both. And it could be a transplant if you can survive long enough and you're strong enough to take one. Okay, so let's talk some meds here. Nitroglycerin we've talked about, right? Systemic vasodilator is going to dilate your arteries. We give it in a glass bottle via central line typically. Sometimes in some hospitals, depending on the packaging they have, you can see them in soft bags, and it's not your typical soft bag. It all depends on the makeup of the container that it's in. It decreases your preload. It's going to dilate the smooth muscles around the arteries, so it lets everything open up. That will decrease your systemic vascular resistance, so the heart has less work to get blood out of it. It's going to reduce your blood pressure. So you got to be very careful. Your blood is pooling in the periphery, and this is decreasing the venous return, which helps decrease the preload, and it makes less work for the heart to do. So the heart's struggling. It's in a cardiogenic shock state. What are we going to do? You know, we're trying to reduce the effort of blood rushing into it that it has to maneuver, and reduce the effort of contraction it has to do to get the blood out of the heart. And it's dilating coronary arteries, which is maximizing the oxygenated blood flow to the vessels. Okay, rapid half-life, it's like 10 minutes. So you shut that drip off, 10 minutes, it's done. You know, the patient is back to whatever they were before, which is helpful. If somebody puts it on and the patient plummets, we take it off real quick and we wait for them to come back up if they can. They do continuous blood pressure monitoring on all these life-saving drugs. And in the ICU, we have what's called an arterial line. We put a catheter in your artery and we put it to a transducer, and it gives us your continuous blood pressure reading on a screen. We'll talk about that in hemodynamics. But if not, if you're in a rig and you don't have an art line, if you are in a hospital, community hospital, and they're not going to put an art line in, this is every 5-minute blood pressures on this patient, constant. You could use a Dynamap, you know, an automatic blood pressure cuff. You could use one of those. So typically glass bottle, all right? Okay, dobutamine, this is also called Dobutrex. You hear that a lot. It's in the formulary in some hospitals and it's trade name. So you'll see Dobutrex sometimes. It increases myocardial contractility and it increases cardiac output, but it decreases ventricular filling pressure because what it does is decrease systemic vascular resistance. So it's for your patient that needs a little kick in the heart rate, the contractility, and needs a little kick in the cardiac output, this is the drug for that patient. However, it's decreasing your systemic vascular resistance. So while the heart will have more oomph when it pumps, it doesn't have to overcome a lot of pressure to get out of the heart. So it's good for some people. Not everybody needs Dobutrex or dobutamine. Not every patient will benefit from it, but for the ones that need it, it's a good drug. So we give it central line, and this one, like many of these drugs we're going to talk about, no bicarb in the same line. And God knows these patients are sick enough they'll need bicarb infusions at some time, but at some point, but in a different line. Don't mix them. Frequent BP assessments, absolutely. And it can cause hypotension because it's decreasing systemic vascular resistance. So that's why. Okay, so dopamine, very different drug. This increases the cardiac motility. It's going to increase the contractility. It increases your heart rate, increases cardiac output, increases your blood pressure. So this is someone that we talk about people being on vasoactive drugs. This is more vasopressive. What's happening here is the body's in trouble. So we talked about yesterday, your adrenals are going to kick in with your catecholamines, your neuroendocrine hormones, and out comes the epi and the norepi and everything that's going, and it's going to clamp down your peripheral circulation because the body, in an attempt to keep itself alive, is going to say, shut down all the periphery and shunt blood to your vital organs. And that's a great attempt, and it helps keep people alive until we can get to them and try and do more. But it's short-lived. How much, if this body is in trouble with other disease or trauma or whatever brought them to this state to begin with, how much can the body sustain that? So what we do is we give them these vasopressor drugs that do the same thing. They're going to clamp down the circulation, shunt blood to your vital organs. And that's why in this case, it's increasing your heart rate, increasing your cardiac output, increasing your blood pressure. We might not want that for the patient before that needed a decrease in systemic vascular resistance. This patient needs help in a different way. Now, low dose, dose dependent is going to tell you which side of the drug it speaks to what receptor. So you can get a beta response or an alpha response. So in low dose, they say it increases renal flow and mesenteric flow and cerebral circulation. And there are some nephrologists who will say if the patient's kidneys need a little bit of a kick, give them low dose dopamine. Some nephrologists will say, I don't bother with that. I don't think it does anything. And you know, you'll see this physician ordering it and you're hanging it, and this one 2 doors down is saying, don't put it up, it doesn't do anything. This has been since I've been in practice, which is not a whole, you know, not a millennium, God knows, but it's just that way. Is the science there? Yes. The science would say in a low dose, it should increase your renal flow because we're speaking to different receptors. In a higher dose, it's going to cause peripheral vasoconstriction because the alphas take over. So your patients in the ICU will have it for the alpha dose. We're not really looking most times for the beta. So it'll be a higher dose and it's for the vasoconstriction. It will clamp down the peripheral circulation and shunt the blood to your vital organs. It's again, central line. Don't mix it with bicarb. It's frequent blood pressure checks. So in most hospitals, especially Maine, you'll have art lines in everybody. It's not a problem. And you have to now do peripheral assessments. What's the concept here? We know this drug is clamping down peripheral circulation. That's going to have an effect on people's peripheral circulation. So you'll first feel that the feet are cold, and then they get real pale, and they can get really bad. Like we'll talk about another drug, Levophed. I've had patients' toes get necrotic and fall off in the bed. You know, it's really, think about the action of the drug, why this is helpful to the patient. What is it doing? Why is this drug shunting blood? How can it do that? It clamps down your peripheral circulation. So you have to do peripheral circulatory checks so that people don't lose their limbs. Okay, epinephrine. This is another one dose dependent. In low doses, a beta agonist. So this is cardiac stimulation, bronchodilation, peripheral vasodilation. It's going to increase your heart rate, increase your cardiac output, decrease systemic vascular resistance. Now, in high doses, the alpha agonist comes out. So it's peripheral vasoconstriction. I mean, strong peripheral vasoconstriction. Your stroke volume goes up. Your systolic pressure, your systemic vascular resistance goes up. You have increased central venous pressures. I mean, everything is up on an epi-drip. Think of what epi does for you. It's your fight or flight thing, right? So when it's high dose, the patient feels it. I mean, they're usually unconscious, but you can see it in them. You can see the body react to it. All right, so here's norepinephrine. This is different. This is commercially known as Levophed. And anyone who's worked in the ICU, the nurses always say, Levophed, leave them dead. You know, it's a very potent drug. And do people come off of Levophed? Yes, I have a career of people that, believe me, come off of Levophed. By the time they need Levophed, does everyone come off Levophed? No, you have to be really very sick. So the beta agonist in this norepinephrine is going to give you cardiac stimulation. The alpha agonist is your constrictor. It shuts down that peripheral circulation, and it works. It shunts blood in, no problem. So it's going to increase your BP in a patient who we can't get anything on for a BP. It's going to increase your systemic vascular resistance because it shuts everything in the periphery closed. And what does it do? It's even constricting your renal, your splenic, every kind of circulation. So you're assessing this patient. All of a sudden you're thinking, where are my balsams gone? Because you don't have splenic circulation. It's cutting down. So this is a really, really sick patient who needs potent vasoconstriction. And these are the ones that I have had people that have lost their limbs in the bed. They've lost toes and their fingers are ashen, and it's awful. I tell the classes I had when we had a different setup for 202 and we had clinical days, you know, you used to come to class Monday and Thursday and test every other Friday. And Tuesdays and Wednesdays, we took it to the hospital, to the ICU. And so I had students in the unit all the time. And this one patient we had in there was on Levophed. Now, she was a really healthy aerobic instructor in Charlotte. And some of the students knew her from whatever Y or wherever she worked, whatever gym. And she was a very, very healthy lady. Well, she came in with a UTI and, well, kidney stone, I guess it was. And, you know, they'll always x-ray your kidney. And if your stone is caught up in your UPJ, in the ureteropelvic junction, you have to stay in because you can get hydronephrosis, you can lose your kidney. If your stone isn't stuck, then they give you a strainer and they give you Toradol and they give you, you know, tell you to go home and drink your juice and water and everything and pass your kidney stone. So she went home, and 4 hours later, she came back in agony, and it was wedged now. It wasn't the first time, but it was now. And she was uroseptic within a day. So she's up in the unit, and she was so bad. She was on Levophed forever, it seems. And this poor soul, by the time she was done, my last group that year, we used to go every 7 weeks. So I did 5 groups a year in 202. My last group saw her, her arms were amputated below the elbows on both sides. And one leg, she had a BKA, and one leg, she had an AKA. And they finally could wake her and get her off the vent, and she was plugged, her trach was plugged. but it was Levophed. But it was a urosepsis that she had. It was really bad. And she was great. You know, I would go in, she was unconscious, and I always talk to my patients, and I'm like, hi, I'm here with, you know, Julie today, and she's your student, and I'm watching her, she's watching you, and you're fine, and I'm just talking to her about all the things connected to you, you know. And student after student, I put in there to see this lady. And little by little, her hands got gray, pale first, and then they get gray, and then they get chalky as they get deciduous. And they wrap them, and they use Silvadene creams and all these things, and chunks of tissue are coming off the bone. I mean, it was so bad. So then she would have to, in this horrible state, go up to the OR and get an amputated limb and come back. And little by little on her feet, we would unwrap them. They were necrotic. It was awful, awful. So think of the action of the drug. Why do we need this to happen? Patients in a shock state. They don't have any of this ability to do it on their own. And if we're going to save their life, we have to try. But with the action of the drug, what can that do to somebody? So this woman was very positive. When she could talk, when she finally came to, I would go in and they said, she's been asking for the teacher who comes with the students. And I went in there and talked to her. And she said, I know exactly who you are. I know your voice. Your students came in. You would always tell them, put their hands on me, so I would know they were there. And, you know, she was lovely to them. But she said, there must be a reason I'm here, and I'll have to just keep going. So she went to rehab. She came back a few times to visit with her prosthetic legs and hands. And she had a real tough time. So anyway, okay. Nipride, we've talked about nitroprusside. So this is arterial and venous vasodilation. Your malignant hypertensive coming in the ED who's 230 over 140 is going to go on Nipride. And it opens those vessels wide, and boom, that BP comes down. So it decreases preload, decreases afterload. It's good for people who are malignantly hypertensive. It's going to decrease your blood pressure. We give it a central line. This one comes with a brown paper bag over it, a brown plastic bag, a plastic sleeve, whatever it is. It must be protected from light. I can't tell you how many times the infusion will come up like that in a bag. It's in an IV bag, and then it's in a bag, and somebody will take the bag off and go to hang it. You got to keep the bag on it. It's very sensitive to light. Only in D5, and they come up most places from pharmacy, but you know, before you hang anything, you have to check it, read the labels, be sure. Only D5 with Nipride. Okay, again, frequent BPs with an art line, it's not a problem. You have them every time the heart beats, you have another one. So it's not a problem. Cyanide toxicity is possible if people are on this for a while. Now, you shouldn't need this for a long time. If we can get your BP down, even the person who comes in with malignant hypertension, if we put you on this so you don't stroke and bleed through your brain, and we get you on this, and in the meantime, we're trying to figure out, do you have a renal tumor? Do you have, I mean, what is the problem that you're having this malignantly high hypertension? Can we control it with pills and wean you off of this so they don't stay on it, not weeks and weeks like they can with vasopressors? So there's consequences here. Seizures, yes, that's always a possibility with anything. But the almond smell to the breath, it's like anisette, if you know what anisette sounds like. It's a very unusual smell to the breath. And it really is, some of the breakdown elements have cyanide, and a person can start to get cyanide toxicity from it. So they watch it very closely when someone's on Nipride. But just to have that little factoid on the back of your head. So other treatments, what else can we do? Diuretics are good. If we think you have too much fluid on board, which is likely not the case in the MI who is now in cardiogenic shock, but it could be. If somebody was in heart failure before they had the MI, it could be. So let's just say it's an occasional use drug. If it meets your patient will be on it. Remember, for diuretics to work, your kidney has to work. So what's the concept here? If you have somebody who's in a shock state, who has a low BP, you need 80 millimeters of mercury perfusion to perfuse your kidneys. You know, so if your patient's been less than that and in a shock state for a while, the kidney's not perfusing. If the kidney's not working, all the diuretic in the world is not going to help. So something to keep in the back of your mind. And always your beta blockers. We have talked about them in every lecture you've had, always the beta blocker. It was a good find, right? We should all have stock in beta blockers. Okay, here is the elusive IABP. All right, so here's the premise for this thing. This is a balloon. They put this on the arterial side. They go in through the groin. Let me find my cursor. They go in through the groin and they come up backwards in the approach to the heart. They'll come up the aorta. It makes it look so simple, right? Go up the aorta backwards and come all the way back in. So by doing this, I mean, think of the risk. This is not without risk. This is a significantly sized balloon. And it comes up this way and it's got a turn and you can nick and hit and do any kind of damage in the world on the way in. So they go very carefully and they bring it up and they leave it here. Now, it's synchronized so that in early diastole, this starts to inflate. And by doing that, because what's going on inside of the heart, if you are in early diastole, blood should be coming through your mitral valve into your ventricle, right? So this balloon is going to inflate and not let anything get out until we're sure it has a nice big volume in there. And then it deflates and out comes the blood. When the heart pumps, a big bolster of blood comes out, a big volume, whatever the heart can hold, comes out. So we're now maximizing your ventricular output. Now, some nurses, I tell the class, I can remember one time specifically, I was working in an ICU and they wanted someone to take this patient into New York City. We were in a large medical center, but it was on the Jersey side of the Hudson River. And this patient has to go in. They're right on the verge of cardiogenic shock, left ventricular failure is horrible, blah, 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 blah. But we'll put a IABP in and then somebody go with them and take them over to Columbia. Well, everyone's like, I'm not going with an IABP. I'm not going with an IABP. If you understand the concept, I must have been the odd one, but I'm thinking I won't go without the IABP because I have to go in on a rig into New York with this lady. And if we have a prayer of keeping her alive, she needs the IABP. I mean, think about this, right? So the other thing is you can't go in a dead ambulance. You know, this can't be your local whatever ambulance. You have to have a critical care ambulance that has what you need. So anyway, we had this lady and she was lovely, but she was in and out of consciousness and she knew she was so, so sick. And so they said to her, you're going to have to take a ride to New York. And, you know, they were going to see what they could do. Valves, open heart, I forget what it was, but she was pretty sick. So they put the IABP in and all of a sudden, you know, we had a little blood pressure and we had some control. It was nice. And so I take all her garbage and in the back of the rig we go. And of course it's 4 o'clock. If you're not from that area, you won't know, but 4 o'clock, trying to get into New York City for people going back into the city and all is ridiculous. So it was a bad time. And we go to get on the George Washington. There's a major accident. And the George Washington Bridge, it's a huge span over the Hudson River, but it's several miles long. But after they built it, it wasn't long before it was always packed. And they didn't know, I mean, what did they do without it? I mean, but now they had it and it was always packed with cars. So then they built the lower span. So of course, New York is called the lower span, the Martha, because it's under the George. So we're trying to get onto the George. There's this major accident. And the guy riding the rig leans back and says to me, we're going to have to take the Martha. There's a bad accident up here. So we reroute, we take the Martha. We're driving along. There's a huge accident on the Martha. We must have been 2.5 hours in the middle of the span of the George Washington Bridge. Had I not had this lady, she made it to Columbia. I don't know what happened to her after that. But had I not had this lady on an intra-aortic balloon pump, there's no way we would have made it there. There's no way. We're lucky patients like that can tolerate the jiggling and manipulation it takes to get them out of the hospital, down an elevator, into the back of a rig to go anywhere, never mind all this. And every now and again she'd come, she'd open her eyes, we okay, Jane? We're doing great. And the guy in the front of the rig would turn and look at me and he goes, we're just doing great. Like, I mean, it was awful, awful. But you can't be in a dead ambulance. You have to be in a critical care ambulance that I had antiarrhythmics, I had anything I needed there. But it was, you know, so sometimes you need this. I mean, for people who need this, it functions well. Okay, let's see. Here's the LVAD. You've seen this already. We've seen this before. This will be, they put it in the bottom of your left ventricle. They put the other piece up here in your aorta, which those are significant anastomotic sites. And it's just going to shunt your blood around. If you work with patients like this, students are always surprised to find they really don't have a pulse. It's kind of like a whoosh sound they have. So of course they go listening and they're waiting for, you know, S1, S2, and that's not what you're going to hear in this kind of patient. But it's a good patient to take care of. They need help. Okay, so what do? You're the nurse. What are you going to do for these patients? They require close monitoring. Absolutely. And we do every system of the body. Watch the neuroscience, watch the cardiac function, respiratory, what are the lungs doing? It changes on a dime. GI, if we're using vasopressors, we're diverting blood. So what's the GI doing? You know, sometimes we can get a necrotic bowel before you get a necrotic foot. It all depends on the patient's vasculature. And they don't have great vasculature to begin with if they're in this cardiogenic shock state. If they somehow had an MI and had some major involvement of something, they have significant disease. So watch their skin. They're probably having episodes of diaphoresis, and your skin is your first line defense, and we need them cleaned. Sometimes all you can do to give people comfort is to give them a bath and clean their skin. So, you know, don't forget people's skin. It's a big part. Watch the temperature. It's going to change the metabolic demands. If your patient is febrile, it increases everything. So watch their temperature, keep them under control. So vital signs, neurosigns, urine output. Liquid gold would be nice. If we're perfusing the kidney, we're going to see we have urine output. If the kidneys still aren't working, it's not going to happen. And if we're giving them all this fluid, there better be the plan B in the works to say, where's the fluid going? Patient can't pee it out, nothing's working, they're not pooping great because their mesenteric flow is decreased. So sooner or later, they may say, this patient needs a little bit of dialysis. Now, the patients who have dialysis in ICU have it much, much slower. They are not hemodynamically stable to take a full dialysis run. And we might know we keep giving them fluids and they're not putting anything out, but they're not stable enough for us to put a VAS cath in and start dialyzing them. So, you know, people are that critical and that much of a balanced issue that it's hard to decide sometimes. So if the BUN creatinine get too high, we have to do something. But it's really tough to take circulatory fluid volume out of somebody and rinse it out in a dialyzer and put it back in when they're already unstable. So we look at all of that. Watch your invasive lines, keep them functioning. You're dealing with central lines when you're dealing with vasopressor. So make sure your dressings are good. I can't stand it when I go in and they've put a central line in somewhere and, you know, you change the dressing within 24 hours, but then it's still, you know, junky and dirty, or if someone has long hair, their hair is stuck under it. It's the other order is for PRN changes. If it's filthy dirty and you see blood trapped under there, blood is protein. So dried protein, this is a petri dish we're creating on their shoulder, you know, or their neck, wherever their central line is. So get the dressing off and make sure the site is clean. So watch your sites. We don't want central line infections. Watch your technique as you're adding drips and hanging things and doing whatever. Be careful of your technique that you don't infect this person. Okay, so nutrition, they're not eating if they don't have good bowel sounds. And so typically they're on TPN. TPN isn't the best source, but it's certainly better than nothing. So we'll take TPN until we get a tube feed. If we can do a tube feed, we do it. If they say it's contraindicated, we're back to TPN. Okay, personal care, we still take care of people. There definitely are patients that cannot be moved too much because their blood pressure can't sustain the change. Just turning them to their left side can drop their BP and send them all over the place. So we have to evaluate that. But otherwise, we bathe everybody. Everyone needs care. It's your first line of defense is your skin. So we wash everybody. Okay, control the stimuli. This is a time for people to come in rooms when someone is critically ill, and sometimes they carry on. You always aggravated him doing this. You were the one that left home and didn't do that. You never worked like he hoped you would. You never. Take it out of the room. I am, so strict about that. I don't want anyone. Hearing is the last sense to go. You have to protect your patient room. I don't mind anybody coming in, spending time with a loved one, but they're not going to be fighting in the room. They have to go. Take it outside. And some families, it's very, very volatile. And you really have to get to a point where you visit certain times of the day and you come other times of the day. I mean, it gets really bad sometimes. So that's something we have to control, that stimuli. All right, we comfort and support them even when they're unconscious. I talk to people all the time when they're unconscious. I tell them everything I'm doing, and you'd be surprised how many people I've had who come out of a coma, not just a medically induced one, like their own coma, and can recount to me everything I've told them. So I firmly believe you have to talk to people. And I don't let, sometimes they're rounding the physicians, and a bunch of residents will come to the door, and you hear them saying, I can't believe this guy's still alive. This guy isn't going to prick. Do I get what they're saying? Yes. Can they say it in my room? No. You want to take this out in the hall, guys, really, because don't let them, talk around your patients like that. Your patient's hearing is the last to go. All right. Don't forget the spiritual need. I don't care what religion somebody is. I don't care what they follow, what their beliefs are. Not my beliefs. They don't have to be. But my need is to meet their holistic needs, and that means spiritual support. So whatever theirs is, I'm going to go into the chart and figure it out and call the chaplain and get somebody up to take care of that. Okay? Everybody has somebody you can call. And if not, I've had poor street people that have come in that we know nothing about. So everybody gets an Our Father. I don't know. I do. Everyone does what they do. And if someone is from another country, speaks another language, I always say to their religious person that comes, if there's a prayer you want me to say that's written in English, leave it here and I'll say it over the bed for them. I mean, it's the least we can do. And in a pinch, I don't know what they are. I don't think God minds at a time like that. You say whatever prayer comes to you. Okay, family support is very important. And there comes a time in ICU where your support of the patient, when the patient dies, we still do dignified care of the dead and all of that, but your care then turns to family. So these are people that you don't know from anybody. I mean, you've never met these people before, but by being their loved one's caregiver, you are thrust in the middle of their family crisis, and they will look to you for support. And they're just, destroyed by what's happened, and they can't imagine it's a harsh reality for them. So keep that in mind. Your care extends to the families in ICU as well. And it's really tough for people. Students often say to me, I wouldn't know what to say to somebody, or we're in a room when someone dies and they'll come out and they'll say, I don't know what to say to them. It's fine to say, I wish I knew what to say, because you don't know. I mean, you're thrust in the middle of their crisis. You want to be there. You want to offer support. Sometimes trying to find some cliche is very empty. And you can appreciate the position they're in and just tell them honestly that you're so sorry and you wish you knew the words to say to help them, to comfort them. It's beyond sometimes speaking, really. So, okay, let's talk about hemodynamic monitoring. All right, some of this stuff because you've done vital signs since probably you were in nurse aid class, right? So what are we doing with hemodynamic monitoring? We are monitoring pressure and flow that's why we take your blood pressure. It's why we take your pulse. We take pulse oxes so we know what your oxygenation is doing. It's important. It helps us see how you're doing, whether or not your heart is basically healthy, are you hypertensive or not, how you're managing your own fluids, helps us manage fluids. If we think your heart rate's too high and your BP is too low, we might think, you're bleeding out. We might think you need fluids. I mean, it gives us some range of assessment, and it helps us also to monitor the effects of these vasoactive drugs we've been talking about. some that are just vasoactive, some that are vasopressive. Okay, so circulation, we've talked about this. There's a set volume of blood in normal circumstances. Whatever comes from your inferior vena cava to your superior vena cava comes into your atria. That same amount goes to the ventricle, goes up the pulmonary artery, goes to the left atria, goes to the left ventricle, goes out to the body again. And as your needs change, your heart is normal and it can accommodate to that change. Your system can accommodate to that change. These people are not in that situation. So blood flow and resistance are a big, big deal here. How much blood you have, if you don't have much, the body overcompensates and stimulates your heart. If you have too much, you have high pressure in the system, and resistance becomes a factor. What's the concept with resistance? You could have atherosclerosis, so you have heart disease. You could have peripheral vascular disease from atherosclerosis. You could have valve disease that provides resistance. If you have stenotic valves, it's resistant to your blood flowing. So, you know, there's many, many things that can affect resistance. Okay, the methods. Non-invasive are what you do already. You know, yes, you put a thermometer in someone's mouth, but other than that, BP is non-invasive. Your pulses that you take are non-invasive. The O2 sat monitors on the fingers or on your earlobes, wherever we put them, is non-invasive. So these are non-invasive methods. We're going to talk about invasive methods. So if we are monitoring your blood pressure from the inside, your systemic venous pressure, your, oh God, in the ICU, we do cardiac outputs and cardiac indices and all kinds of things based on equipment. The thing here is when you deal with invasive monitoring, it has to be technically accurate. And one of the criticisms people have of those of us that have worked in ICU is it's all the machines and all the machines. Yes, you have to know all the machines. You have to know all the patient first. You have to know everything about the patient, what's going on in the body first. But yes, there's a lot of equipment and a lot of machinery you have to learn to maintain. The information we're getting from the machinery is only as good as our calibrations. We have to be sure it's set right and everything's fine, and then we'll get reliable results. So we'll talk about CVPs and, you know, Swan-Ganz catheters and art lines and all that stuff. Okay, so cardiac circulation, this is your review, brings you back. These definitions probably sound a little familiar, and we don't test you on this. This is just your frame of reference, cardiac outputs and index and systemic vascular resistance that we've talked about, ejection fraction, the percentage of blood that goes out of your ventricle and systole, and stroke volume, basic tenets of heart. So Starling's law explains a lot for us. It talks about the effects of preload. And what Starling's is saying is basically, it's a very simple principle. The more your atria has to expand to accommodate the volume of blood coming into it, then the greater it's going to shorten when it's in systole. This makes sense to you. If you extend it this much, you have to come back that much to pump it out. If you extend it this much, you have to come back this much. It's just saying it's equal and opposite, okay? But take that concept, and now Starling's is saying, so that affects that beat going into your atria. It's going to affect your stroke volume, your cardiac output, because all things being equal, what's going into that atria is the same that's going into the right ventricle, the same amount that's traveling to the pulmonary artery into your lung, coming back into your left atria, going into your left ventricle, and out to the body. So the greater the myocardial stretch is also the greater the oxygen need by the myocardium. So it seems a simple principle, like we want to say Starling's didn't know that, but we know that because of Starling's. So, all right, so preload. Preload, we're talking about what's coming into the heart on the right side, all right? This is a pressure reading rather than an actual reading because we can't get in there to see what it is. When we talk about preload, that same amount of blood coming into the atrium is in the right ventricle. We're saying for the right side, that is right ventricular end diastolic pressure. Right ventricular preload and end diastolic pressure are one and the same. What does it mean, right ventricular end diastolic pressure? It's not a fancy term that is confusing. Think about it. It's the right ventricle at the end of diastole. So diastole is filling, right? At the end of filling, what's the pressure? So we can't get into your right atrium and say, let's throw a pressure gauge in there with continuous beats happening and see what it is. So how do we estimate it? The only way we can measure it before it gets in there is when it's in your central line, when it's still in the CVP, when it's still in your vena cava, right? Get a central venous pressure reading. And if we're saying what comes in at that point is the same that goes to the atria, same that goes to the ventricle, same that goes to the lung, let's catch it here and measure that. So they put a central line in and they measure central venous pressure. Put it in your subclavian, you know, they put it in a venous side because the venous side goes into the heart. And we're going to measure that. It's a scale of 2 to 6 generally. Okay. Now, left ventricular preload is the same thing as left ventricular end diastolic pressure. And it's no big thing either. It's two terms that mean the same thing, but think about it. It's what's in your left ventricle at the end of diastole. So once your ventricle, if we could stop your heart dead and say, all right, it's full after diastole, stop it now, crawl in there and see what the pressure is. That's how we could get a pressure. That's not possible. So we're saying the left ventricular end diastolic pressure is what's ready to get fired out into the body. What is that pressure? Well, we can't get onto the left side of the heart to tell. What we can do is we can go into your pulmonary artery. We can go down the right atria, into the right ventricle, up the pulmonary artery, and just as the blood is leaving to go to the lungs, we can take a pressure reading. We can inflate a balloon and block the blood flow instantaneously and measure that pressure beyond that point. That's really measuring pulmonary capillary pressure, because the next stop for that blood is your pulmonary capillary bed. But we can't get any closer than that. And all things being equal, that should also measure what's coming into the left side of your heart and into the left ventricle. So it's only an estimation, but we estimate that it should be, 6 to 12. And it's just a guideline. So that's our ways of measuring preload. Hang in there. This is afterload now. We've talked about this too. This is what your heart has to overcome to get blood out into the system. So afterload, we're like, oh, okay, this is pressure. This is what's the opposing force? If the heart wants to do its dub and get rid of the blood and send it out, what's opposing it? What's making it difficult? Could be the aortic valve. Maybe it's stenotic. Could be the aortic valve that it's regurged. So the blood goes out and comes right back, and it's not effective. It could be systemic vascular resistance. This patient could be hypertensive. So the heart feels okay, but it's trying to get blood out, and the person is so hypertensive, it's hard to get blood out over that. So we're going to reduce that pressure. It could be the mass and the density of the blood. It could be that somebody is, dehydrated, they've been stabbed or shot, they're bleeding all over the place. The heart's pumping fast to try and do something. The blood is just not even having time to really fill well in the heart because it's trying to keep up with this fast heart rate. And that's impeding it. So it can be many, many things for the afterload. All right. By reducing the afterload, we know we can improve cardiac output because we don't want this rapid heart. We don't want little spurts of blood. We want to improve the contractility. Let's get more blood in the ventricle before it pumps so more goes out. And by doing that, if we can improve cardiac output, we can reduce the demands of oxygen on the myocardium. Makes sense, right? We've heard this thinking before. Okay. So here's your graphic on preload, afterload. And this is on any search engine again, but it gives you an idea of, people think of it as a loaded gun even. All right, the gun is loaded and then it's going to fire off. And it's what's coming in is your preload. and look at coming out, and look at the clamp here to remind you systemic vascular resistance can be a big issue with afterload, which is why I was saying the other day, the discovery of the ACE inhibitor was a huge bonus in that area, because we know now interrupt that angiotensin 1 to 2, and we can stop that vasoconstriction that happens naturally. So that was a big help. Okay, let's come back over here. All right, so contractility concepts. What are we talking about, contractility? Positive inotropes increase the force of a contraction. So this is a good thing. If we need to increase force of contraction, what do we need? A little epi, a little norepi, a little isoprol. They use isoprol sometimes. Dopamine, dig, whatever. Negative inotropes decrease contractility. So calcium channel blockers, because they're blocking that calcium shift that's going to cause contraction. Beta adrenergics that we're always talking about, our dead horse that keeps coming back. There's no direct measure, but invasive monitoring gets us as close to an estimate as we can get without being inside the heart. So they're important. Okay, so what are we looking at? They're used in critical care settings where they're monitored, and hemodynamics is of prime importance. You don't find them really out on the floor. We don't have Swan-Ganz and art lines out much on the floor. It's going to help us determine their vital functioning, how their body's working. It helps us with fluid volume control, because if something's telling me you have high pressure in the left side of the heart, I might be hesitating to give you fluid. Let's say your output is poor, your urine output is poor, and the doctor's saying, you think the patient's dry, or you think the kidney's involved and the kidney's not working? Well, if we have a Swan-Ganz in, we can do a pressure reading and say, well, the pulmonary pressures are high, the pulmonary artery wedge pressure is high. So it's giving me an indication that there's fluid on board, but we don't have liquid gold. Let's draw another kidney panel and see what's going on, see what our BUN creatinine look like. Things like that. It's going to help you rather than just say, oh, let's give them a little fluid bolus and see. Maybe not the best thing to do if they're already in trouble. We also take into account the other assessment factors that are so key. Are you hearing wet lungs? What's our labs look like? I mean, we take into account other things, but these people are so tenuous that we want to use all the tools we have to be a part of the puzzle. So it's referenced and zeroed every piece of equipment. Anytime you move the patient, anytime the patient's been turned, we keep the main transducer at a fixed location. But if we toss and turn this patient, change the bed, take them out, put them somewhere, send them to some, MRI or something, bring them back, everything is recalibrated again. Because we are not going to act on equipment numbers we're getting from equipment that we are not sure are 100% accurate. So your equipment has got to be right all the time, okay? It's a very important part of invasive monitoring. Okay, it's 10 till, why don't you take a break and we'll come back at the top of the hour and we'll get into these a little more, okay?
Janie?
Yeah.
I have a question. So with the transducer monitor, you were saying every time we move or the patient moves positioning, we have to recalibrate and back to zero. Is that okay?
Well, we recalibrate. We'll do that in a few minutes. I'll show you, but we have to recalibrate it so we're sure everyone's always measuring from the same standpoint. Everyone's always using the same markers. The machine is all cleared and zeroed. We have to be sure everything's right.
Okay.
Yeah.
Got it. Thank you.
Yeah, you're welcome. Huh? Is it on now? Do you see it?
Yeah. Yes.
Okay. Okay. Maybe I hit it twice instead of once. I don't know. Okay. So let's talk about invasive pressure monitoring tools. So I've mentioned the ArtLine, a pulmonary artery catheter, which is your Swan-Ganz, these two doctors that developed it, and your central venous pressure catheter are the ones we're going to talk about. There's more, but these are your general principles that reflect the hemodynamics and the basic principles we use to monitor them. If you worked in an area that uses others, then you learn those as you go. All right, so the equipment. We have to start with a pressurized bag of solution. Now, I have here, I have toys. We start with a pressurized bag. Now, under here is just a regular IV bag of fluid. It's just a normal saline. Let me get it off of here. And what we're having to do is, because this is invasive and these are in the vascular system, we're supplying, like this is just a regular normal saline bag, okay? And we put it in the sleeve that is then pressurized. We're gonna pump this up to 300 millimeters of mercury because we're now using a monitor that is inside the system. And when you measure someone's blood pressure, 300 millimeters of mercury is your top line you can go, right? Hold on, I have an ad here in my way. So that's the most you can go is 300. So we supply that counter pressure. So we take a bag that's pressurized for IV solution. And according to some hospitals' policies, I've worked in many hospitals, some like heparin, a little bit of heparin in the bag, some do not. I would say most do not that I've worked at. That doesn't mean most in the world don't. But the thing is, the risk is HIT. You don't know which patient coming in is prone to heparin-induced thrombocytopenia, so we don't want to give heparin if we don't have to. And the idea that the line is pressurized, it gives 3 to 6 mils, depending on the tubing, automatically. So it keeps the line open in spite of us doing all this monitoring and everything. It keeps it continuously flush. So they're fine. They don't clog off. So we have a specific tubing that comes from the bag all the way down, and it goes to the transducer. A transducer is going to take pressure waves and convert it into a picture on a monitor for us. So it sounds a little jumbly and weird. It becomes clear. Hold on. So then we have an amplifier cable that comes from your monitor and connects also into the system. And this is going to amplify this pressure reading we're getting that's going to give us waveforms. So you have specialized catheters. These are arterial lines. They are not regular angiocaths. They're arterial lines. And they're bigger and longer and thicker, and they go in an artery. These are central venous pressure lines. So they're central lines that we can hook up to manometric readings, to pressurized readings, and the pulmonary artery catheter, which is your Swan-Ganz. We can call it pulmonary artery catheters now because they have a priority contract for so many years, and then the contract, expires, and what's always known as the proprietary name Swan-Ganz is truly a pulmonary catheter, but they don't have to call it a Swan-Ganz anymore. Some other company could come along and make a knockoff of the same catheter and, you know, call it Benetti something. I mean, it can be anything. So the concept is it's a pulmonary artery catheter. Okay, all components are disposable. We reuse nothing related to any of this, all right? So it's all chuckable. Okay, so how do we set this up for the patient? We're looking for what we call a phlebistatic access. And the way we find that, look at our picture here. We're gonna imagine this patient flat on his back, and what we estimate to be the halfway spot anterior to posterior chest. What's the halfway point? And we usually go by the fourth intercostal space. Well, how do we know what that is? It's usually right below the nipple line, and we're gonna mark it. They get a Sharpie, they get something indelible, and they mark it right on the patient's chest. There is no question, if I'm admitting this patient, here's the mark, anterior to posterior, fourth intercostal space, just below the nipple line, here I am. And I mark the patient's chest. Anybody coming behind me knows that's my reference point. That's absolutely my reference point. It's on the man's chest, the woman's chest, you can't miss it. Okay, so we're all using the same one. Then, as we set up all the equipment, the pressurized bag, the line comes down, the cables are hooked up to the monitor, everything's set. The transducer has to be level with that point. So most of them have carpenter's levels, or most units have laser now, where you just set it up and lock it on, and the laser beam tells you how far off you are, and you move your patient accordingly. So we're gonna get the same spot every time. That's called a phlebistatic access, okay? All right, now, this page also talks about referencing and zeroing. Referencing is just making sure that before I start all my testing to get a reading, my transducer is at the level of my phlebistatic access. That's reference. Zeroing is done on the next page. Let's see the next slide. Nope, this isn't the picture. Let me go over here. Well, let me stop here and talk a minute. Okay, so we have the phlebistatic access, and it's marked and we're all set. And the transducer is fixed on the pole. When I have the IV pole up next to this patient, I'm gonna lock it right there. And it's marked that this is the spot for this transducer. You know, this is in line with the patient. You know, make sure the patient, if they've come in to do a chest x-ray on this patient and they've moved him at all, I have to get him down, get him back in position, get my laser or my carpenter's level, whatever the unit has, and make sure my transducer is at the height of my phlebistatic access, okay? Now, to zero the line, I'm gonna turn this line off to the patient so they're not getting any fluids, they're not getting any, they're only getting that flush bag through this line, not getting any fluids or anything. And I'm gonna turn the other stopcock open to air. Open the line to air. So it interfaces with atmospheric pressure. Now, I'll say this more than once because I know I start to talk about it and people are like, ah, okay. Atmospheric pressure without any of this, you know, if we're just in a science class in 8th grade, atmospheric pressure is 760 millimeters mercury, okay? For us to start a measurement from that point to say, okay, well, that's atmospheric pressure. So anything above that, well, this patient will be at, you know, 782, or this patient's at 786 or whatever, is not helpful. So we interface the line itself that we have lined up with this patient. We turn the solutions, everything off to the patient, open the line to air. We go to the monitor and hit the 0 button. And what we're saying is whatever reading this is, when the fluid in that line matches the air interface, when they come together, we're calling that 0. So atmospheric pressure may be 760. We're saying where they meet right now, this reading I'm getting, I'm calling it 0. Okay, that's zeroing. We're zeroing the system to a simpler scale so we know what we're looking at. Okay, then you close the line to air, you turn it back open to the patient, the line is fine. And then any readings you get after that are all on the same scale. That's the important thing. Okay. Now, as I said, anytime we move the patient around significantly. So did the bed go up? A doctor came in to see them, really tall person, elevated the bed so they can change the dressing, whatever they're doing. And then did the bed go back down? Maybe not. I come in after them. I'm like, oh, wait a minute, the bed's moved. What's happening here? I can't trust my readings right now. I'm going to reference to my phlebostatic access, and it's up another 6 inches because the person was tall. I bring the bed back down. I line everything up, make sure it's right. Off to the patient, open to air, zero the line, everything's good. Close the line to air, open it to the patient, I'm good to go. Any readings, any waveforms I'm getting on the monitor now are as accurate as I can make them. Now, in theory, the head of the bed up 45 degrees should read as though they're supine. That's what they tell us in theory. But when you're dealing with vasoactive drugs that could save someone's life just as soon as they could kill them, you have to be very, very careful. So if your patient's been up or down, they're likely never sitting straight up because they're so sick. But if they've been rolled over for something, had a tube put in, a nephrostomy tube or something put in their back, had some procedure, had a lumbar puncture, something, they've been rolled back and forth, you're going to reassess all your equipment before you trust your readings. All right? You don't make changes in drugs, titrations, based on numbers you're not sure are accurate. You have to re-zero and re-reference your patient. Okay, let's look at a few more slides, and there'll be a picture here, it might make it a little clearer. All right, so arterial lines, we're gonna put that big long angio, it's fatter and bigger, and the doctor comes and puts it in the artery. Now, it's good to monitor someone who's hypertensive or hypotensive. We need an accurate blood pressure reading. That's what we're looking for. It's good for your shock patient that we're trying to manage fluids and we're trying to see which way are they going and is the BP enough to sustain perfusion to the kidney and the mesentery and the brain. Is it respiratory failure where we're constantly doing ABGs? Instead of constantly stabbing the person's radial artery, we have an art line. Now it's many intrusions into an internal system. Your technique has to be impeccable, but you can go into the art line and get an arterial sample and go draw an ABG that way. So we're not constantly puncturing the patient's artery. Neuro injuries, it's helping us. Is the patient bradycardic from neurogenic shock? Are they bradycardic because on top of their neuro episode, they're having a heart issue? What's happening? So we need continuous monitoring. We want to look at this. Any kind of cardiac issue, any kind of vasoactive med your patient is on, whether they're on pressors or, nitrite or, whatever they're on, anything like that. Now, there's other ways of doing this. Blood pressure monitoring and APCO is one of them. The cardiac output's done from arterial pressures is one you might see, but we still do, you see art lines a lot. They have multi-purpose and they're good to have. They tend to go to the radial arteries. If they can't get into your radial artery, because let's say you have a fistula already in this hand, they're not going to go there. Maybe you've had an injury in this hand, or we have other, you have a pin through your arm, or you have some other trauma-related injury, they can always go to the groin and go to your femoral artery. Do we prefer they not be in the groin? Always, because it's sweaty, it's dirty, it's hairy, it's dirtier. The increased risk of infection is there unless you keep your site clean and keep your dressings intact. So that's another option. Okay, so here's, let's say, our arterial line. Let me get my cursor. So this doesn't look like there's a pressure bag on it, but there is. Here's your inside bag. This one is just clear. They can be black covers, they can be blue Velcro wraparound covers, they can be any kind of cover in the world. It's the concept you have to understand. Some of them have an ad for the hospital on there. We could have a white one with Atrium colors all over it saying Atrium is a great place to work or something. Could be anything if it's a pressure bag. If it's just like a blood pressure cuff that is on the bag. Okay, so then this is your flush solution. At Maine, they are not heparinized, but you might go to a hospital. I worked in one once that they were. So it comes down here, it's a thicker line, almost not frosty, but a little more I don't know what the word for it is. It's not opaque because you can see through it. I don't know if you can appreciate looking at it here. Can you see that? How it's kind of foggy, maybe is what I want to say. It's foggy looking. So it's different and it's a little firmer, you know, and it comes down, it has a slide clamp here. It comes down to a 3-way stopcock. You've seen stopcocks before on things. Then there's a transducer right here. This line gets hooked up to your cable. It's going to transfer the pressure readings to a waveform. Then we have a continuous flush valve. Well, why do we have this? If I'm doing frequent ABGs and I go down to this site, down here, because it's close to the patient, and I turn the stopcock off to the patient, so it's open, off to the mechanism here, the line, so it's open to the patient, and I put my syringe in there and I get a specimen and I take it off and I close the line again and I go run my ABG, I can still have residual blood in here. If I hit this automatic flush button, it takes 3 mils of that fluid and just flushes. You could hit it again and again, make sure your line clears. So that's why we have a flush button. Then this is pressurized tubing all the way down here. This is your specimen collector site. It all depends how the line is set up, the product, if it's Baxter, if it's, you know, who knows, each one has a little bit different. Some of them, this stopcock is right here at the juncture. Some it's maybe halfway up, it's probably around here. Doesn't matter, it's the principle of the thing, it's the purpose of it. So you get your specimens and all out of here and it's connected in here. No infusions through here. You don't put meds through arteries, you don't do any of that. We're getting blood from this. And we're getting pressure readings that we need. So we're getting a continuous BP. It's going to give us a systolic and a diastolic pressure. I'll show you a waveform on another page. Okay, so what else? You can program high and low pressure alarms. So if for some reason your patient is prone to episodes of hypertensive crisis, maybe our FEO, you know, where they have these episodes of hypertensive crisis, you can set an alarm that it will ring if the patient goes above a certain systolic or diastolic. Now, the risks involved. Well, we're sticking an artery. You can always get infection, especially if you're doing frequent ABGs and you're in and out of that line all the time. You have to have impeccable skill. You have to change the lines per protocol. So we're not leaving the same line in there day after day after day saying, well, it seems okay. It doesn't seem like he has bugs. We don't run the chance of having bugs. You can, it's in your artery. You can have a loss of blood supply to your hand. This becomes more mundane if your patient's on a pressor, which a lot of them are, because we know the concept is that it's constricting your peripheral circulation. Periphery in your hands is your hands. And here we have an outline right here, interrupting flow as well. They do the Allen test, just like they do for fistulas. They hold the patient's hand up and they block off one artery at a time, the radial and the ulna, and they see if the hand blanches. Do you have enough collateral circulation to accommodate? Okay. Now, if your patient's on an outline, part of your regular assessment is looking at their hand, feeling it. What's the color? What's the sensation? What's the movement? Can they move their hand? If they're not able to follow commands, can you move their fingers? What's the sensation if they're alert? Can they feel you touching them? CSM is important. We need to know color, sensation, and movement. Okay, so that's a big thing there. They can also have arterial spasms. So you'll have a nice tracing, and you get like this frozen screen, this wacky reading, this reading out of nowhere. Remember, arteries have musculature in them. So if it's irritating at all to this outline, it might not give you good waveforms. If you don't have good waveforms, we're not trusting the reading. So a doctor may come by and say, this is arterial spasm. Now, could they give them a little calcium channel blocker and fix that? Yes. Can the heart stand that if they're in cardiogenic shock? Maybe not. So they'll say, use it for blood draws only, don't rely on it for BP. So now you're back to your automatic cuff, okay? Sometimes they'll move it to the other side and see if it's better. But if it's not a reliable reading, it's not doing you much good. All right, here's the picture it's going to give you. This is the perfect artist representation. This is your diastolic as it's filling, your systolic as it's filling. Then it comes down, you have this, what's called a dicrotic notch. And that means It's going now to diastole. So you see it goes up and it comes down. Now, in real life, it probably looks more like this. This is for educational purposes, really. So this is probably what it looks like, and that's what you need to see. This is overdamped. This is not good. And this is underdamped. This is not good. So looking at this and relying on those readings is giving you false information. Don't adjust your meds unless you're sure your equipment is right, and then you can base your adjustments on what you see for all your assessment data. Don't do it if you walk in and you see this overdamped waveform here. I'm not making any aspersions on this and changing any meds related to that until I go back and re-reference and zero everything and make sure everything's right. Pressure in my bag is 300. Everything's right. All the connections are tight. Everything's good. And then you can move on. Okay.
Jane, I don't know if you said it or not yet. Are nurses changing the art line?
The tubings? Yes.
Yeah. Okay. Do we put it in the first time, or the doctor does that?
No, you don't put it in the first time.
Okay, but we change the tubing.
Yeah. Okay. You got to watch your technique. Be very careful. All right. So now we're going to talk pulmonary artery pressures. And this is your PA catheter I told you about, Swan-Ganz. Swan and Ganz were two doctors out in California who, you know, they were out on, I don't know what bay, San Francisco Bay, Santa Monica Bay, I don't know where they were. They were out on a bay one day and watching boats and just kept looking at the sails, how the boats could change every which way based on a sail. So they started looking into that. They were also doing a lot of cardiac research. And there was a guy many years before who put a catheter similar to this in his own heart to try and see if it worked, to get people to buy into it. I mean, it was like in the 30s. It was when we didn't have any of these materials or anything. We got all this from space. So, you know, this guy, everyone thought he was crazy back in the 30s. But anyway, so this Swan and Ganz guy, these two guys come by and they said, you know, what kind of premise could we use? If that kind of balloon pressure, flow related, the airflow changes and these boats capture the sail and it takes them in a totally different direction, how could we apply this? So what they did was come up with this pulmonary artery catheter. And from space, they had the technology to do multiple lines within a single line. So you have this big single line, this yellow thing, and yellow was their hallmark. I mean, it doesn't have to be yellow, but that was theirs, so that would be noticed. And then you have multiple lines coming out of this one line. And we got this technology from space, from the sleeves of spacesuits. So they used that, and they used what they kept seeing was a physical principle on the bay with these boats. So they decided if they came up with a big long line and they put a balloon-tipped catheter on the end, they might be able to get this line in the right atria, in the right ventricle, turn it, inflate the balloon, and have the flow of blood directed up into the pulmonary artery. And they were right. And now we have this Swan-Ganz catheter. So that's what we're talking about. This is managing people with significant cardiac and pulmonary issues. I mean, they often put them in really bad liver patients before liver transplant surgeries that they think are going to be dicey because they're multi-comorbid. So they'll put it either in your internal jugular or they'll put it in your subclavian and they thread it through the heart. Now, this is no joke. This will have a guide wire in it, and it goes down into the heart, and there's a lot of blood movement, and it's moving around. And when you see them inserting them, the heart is annoyed by this, and you start seeing all these different rhythms. Some of the rhythms we see on the screen lets us know what chamber we're in and how we're getting where we're going. But it goes into that right ventricle, and you see all kinds of ventricular activity. It's not very happy to have a wire dangling about. Now, it allows us to manage the fluids for sure and take pressure readings. It's great. But think about it. We're going down into the heart. We have to get through valves. Don't get caught up in the chordae tendineae. Don't get caught up in the papillary muscle. Don't pull too hard. Don't go through the first valve unless the valve is open or you're going to make a valve tear. I mean, think of the skill involved in doing this. And it drives me crazy in the ICU. Sometimes people that work in the ICU think it's just too cool to be in there. And that's not usually the kind of people we want in there. Like most times you're working you don't care who's around you. Your head is so consumed with the business in your patient's bed that who cares? But every now and again, you get somebody that, oh, I wish my friends could come through and see me in here, and you're like, huh? You know, your friends will come in and think you're crazy. Everyone in the hospital thinks we're crazy working there. So, but every once in a while, somebody like that's a little dangerous because it comes to taking out a swan, and they're like, oh, I pulled out a swan today, and they just pull it right out. It's so cool. And a lot of hospitals, they'll only allow physicians to do it because sometimes the nurses get a little too zealous, thinking it's a cool thing to do, and forgetting you're yanking it out of the pulmonary artery, back through the ventricle, up through another valve, that you could be tearing anything all the way out. So you have to have great appreciation for these lines that are in people and the implications that come with them, you know? All right, so it's gonna help us regulate the fluids and hopefully keep this patient safe. So that's a good thing. All right, so here's the route it takes. This in a blown up picture, at least on mine, is a little fuzzy, but all right, so they're gonna take it in through the venous side and it goes down into delicately through the valves. It's gotta take a sharp turn and go up this way. It has a guide wire, which also tickles the walls of the ventricles, which is not too appreciated. And the whole time they're giving it slack. It goes up through this valve and up into the pulmonary artery. So it's not without its problems for sure. And you don't want an infection in this line either, because it's going to give you an endocarditis. A patient's going to have 10 times more problems. So you have to be very, very careful. Appreciate what it is you're doing here. Okay, so how can we monitor? Well, the distal lumen, all the way to the end, right? It's distal to the patient. And my balloon is deflated because when we had the ground-based class, I would pass it around so people could see it inflated. And of course they have to play with it and they break the balloon. So that's why we kind of have nice things, you know? And since it's like a $10,000 line, it's not as easy to replace. But anyway, there would be a balloon on the end of this. Once it's in the pulmonary artery, and they can tell by the waveform, they will wedge it. It's called the pulmonary artery wedge pressure. On the end of one of these lines, I don't know if you can see that, on the end of one of these lines, there is this syringe. Now, it's an unusual syringe. It has a lock on it. If I show you here, can you see this? Let's see. See how this arrow is not lined up. If I move it, I can get it to line up. It'll line up straight this way. That means I can put air into it, okay? If it's not, if it's like this, we can't accidentally put air into this line. So we leave it locked until we need to use it. The syringe that goes on the end of it, I don't know if you can see this real well on camera. It looks like a regular 3 milliliter syringe, except it won't let you go past that much. It won't let you go past 1.5 mils because they don't want you overinflating the balloon and popping it or infarcting the pulmonary artery. So it has on the inside of it, how can I turn this that you can see? On the inside of it, there's a little bitsy plastic thing that blocks it from going more than 1.5 mils. So that's on the end of this site that we inflate. So they inflate it, they put the air in it, and then they change the arrow back to, after they deflate it, they change the arrow back to a lock state. Now, when you put the air in, it's a few seconds most, because the concept behind what you're doing is you're inflating a balloon to block blood flow coming from the right ventricle to the pulmonary artery so that we can get a pressure reading beyond that point, which will reflect to us the pressure in the pulmonary capillary beds. So in the end here of this tube, we have a mechanism that does pressure readings. So the balloon inflates all around here, blocks off that, wedges off that pulmonary artery, and then we get a reading beyond that, and then we deflate that balloon quickly and let the blood continue to flow. I have seen people do these wedge pressures, you know, sometimes residents, I saw a fellow do it one time, and leave it inflated, and the patient died. So you have to be very cognizant of what you're doing when you get a wedge pressure, all right? So You have two proximal lines, and they say right on them, let me find you one so you believe me, here. This one says, I don't know if you can see that. Can you see that? That it says proximal infusion. So the two lines say right on them proximal infusion. You have, here's the blue one is proximal also. You have another one that says distal. You have one that says PA distal. So this is your pulmonary artery line distal. So they're all labeled, so you know which one is which. You have the different ones to connect to the monitor, to do pacing with. Some swans are pacing swans, some are not. Some monitor SVO2, some don't. It all depends what the kind the doctor wants in on the patient. So we can do continuous cardiac outputs, and they do this old-fashioned way. You see there's a bronze coil along a section of this line, and by injecting cold water on this end, we measure temperature on this end with the coils, and it tells us the degree of, there's a whole formula that gets plugged in, the degree of temperature change, volume that was instilled, and it lets us know what the cardiac output must be for it to get cleared. So it gives us a rough estimate. Multiple ways. We can do continuous cardiac monitoring just through computers now. There's multiple ways of doing it. So we can do blood draws through here. We can give blood through here. I mean, these lines are great. You know, these lines are great. They're really multi-purpose. And Swan and Ganz always said it was space. And it's just good use of something we know already, applying it to something else. So here's your pictures. So the typical one is yellow. That's your typical Swan Ganz. Here's your line with the syringe on it. See how the arrow lines up? And there's a dot right about there on the inside of the syringe that won't let it go any more than 1.5 mils. So that's all you can put in the balloon. The balloon is all the way down here. See on this picture? That's your balloon over here. And you can see your arrow over here. And there's a blockage up here, so you can't extend it anymore. And then after you would do that, you switch this bar so that it's off. It doesn't line up, and then you know it's off. And here's your different ports for fluid and blood. And you have a port you can do continuous monitoring. You have a connection. There'll be a cord then that connects to the monitor to give you waveforms. So now you can give different meds, even incompatible things in this line and something different in this line that's incompatible with this in the same line. So you could never give these two drugs together, but you can in a Swan, because the premise is think of the volume of blood going through the heart and think of where the ports exit. One port is all the way down here at the end, the distal lumen. One is up here. And there's so much blood mixing with every heart rate, every heartbeat, that it's not the two drugs given together. So you can give even non-compatible drugs through different ports of a Swan, and it's still allowed to go in. So that makes them very useful also. Because what's the point in having this great central line and having to stick them peripherally to give something that's not compatible? Okay. Let's see. So your PA is telling us indirectly about your left ventricular function. So typically PA diastolic pressure, just as a guideline, they say 4 to 12. Okay, the wedge, 6 to 12. Okay, that's good. And then there's sensitive indicators. So we look at them, and every time we zero in reference, we know our readings are reliable. We're looking at our waveform and getting a reading, and where does it fit on this average scale? All right. IV therapy is administered solely, really, from these readings, if they're good and the readings are good. Not that we're not looking at other assessment data. We're going to look at lung sounds, we're going to look at kidney function, all of that. But if your patient's in cardiogenic shock, they may sound like they have the same fluid or backup of blood in the lungs that they've had all along. So is that really giving you an indicator if they're in fluid volume overload? Not if the heart's just not pumping well and you're getting backswash of blood in the lungs. So are your kidneys dead or are they not perfused? Could they function if they had fluid? We don't know. But going by our readings and, you know, looking at all other odds, we're going to go by the readings. If your kidneys aren't reliable and we can't go by urine output, you know, BUN and creatinine, BUN is affected by so many things. Your BUN could be up just because you're in cardiogenic shock. So it may take a while for your creatinine to catch up. So sometimes we have to go by something, and we'll go by our hemodynamics because they're at least on the inside. Okay, so here's your, what else? It allows us to measure SVO2. So we just talk a word on SVO2 because it's not really a concept on ADN level in pre-licensure, but you're going to see it all over the hospital if you're in that area. So SVO2 is mixed venous sampling. And what do they mean by mixed? It's your inferior vena cava return as well as your superior vena cava return. And so it's important for us to look at and say, what is it telling us about oxygen consumption and the ability to deliver it? You know, so they want to get an idea on the venous side. We know what it is on the arterial side. After it's gone out to the body and supposedly delivered, what does it measure now in the blood? You know, so that's what they're looking for when you hear someone talk about SVO2. So the wedge pressure we talked about is a fixed amount of air in the syringe, and you inflate it briefly so that it doesn't rupture the vessel. The normal pressures we know, if the wedge pressure is high, your patient could be fluid overloaded. They could have renal disease. They could have, it could be their left ventricular failure, sometimes an impending left ventricular failure. Look at the transplant, the liver patient I told you about. Him coming in with all his comorbidities, he might have a SWAN just to be sure we're monitoring everything because he's having this gigundo surgery. And all of a sudden we see his levels going up. So is he suddenly going into left ventricular failure? Could be. So it could tell of impending failure. In the cardiogenic shock patient, it's going to validate to us how to regulate the fluid with known ventricular failure. Okay, if it's low, they could be dehydrated. Maybe we can safely start giving them some fluids. It could be, let's look back on the MAR. How much diuretic therapy has this guy had in the last 24 hours? It could be he's bleeding somewhere. And if they're in cardiogenic shock, BPs are what they are, but what in the world? You could have what seems to be a decent BP, but the patient's on vasopressors. So are we going to see that if they're bleeding? So we got to look for other things. And you'll see in the ICU, they start scanning people. You know, run and scan that head, see what's going on. You know, they start questioning because we can only go by what we know. We don't have an inside look into every organ, but we know all the complications that can exist. So it gets pretty dicey, but it's fascinating. It's very interesting. Okay, so pulmonary artery, I told you can measure cardiac outputs. We can either do it bolus-wise or we can do it continuous. And you don't need to do it just through a SWAN. There's other mechanisms as well, but it's one of the capacities it has, which is good. All right, so let's look at this. Now, I tried this before class today, and let's see if it works today. I told them yesterday it worked one time and not another. Let's see. Let's see if it will come up. Is it coming? Oh, come on. Oh, God. No. Oh, this could be good. Hold on. This could be good. Let's see. All right, you probably can't see it. Let me go to screen share again. Hold on. Hold on. Oh, it's not going to let me screen share. You can't see this, can you?
No.
Oh, God. Okay, well, I don't know. All right. Well, anyway, the link is good. Sorry, guys. The link is good. And certainly, by all means, I can't believe it. Well, okay. By all means, if you can just take the link and it's, it'll open up from any search engine that you're on. Let me get us back here. Sorry, I thought it would work today. I try it ahead of class and sometimes I can get it. So it gives me hope, you know. but not to be today. All right, well, let's see. Okay, and let me make sure you can see this. Can you see this still? No?
Yes.
Yeah, we can see her.
Okay, all right. Good, good, good. All right. It's not lighting up like you can see it, so I want to be sure, yeah? You got it? You can see this slide that says PA catheter insertion video?
Yeah.
Yes.
Okay, it's not lit up. Usually it lights up to let me know that you can see it and it's not lit up, so I want to be sure. Okay, did it now switch to a new picture with 4 pictures of heart?
Yes.
Okay, well, go figure. It's just not giving me the, all right. So here's another picture of your Swan-Ganz, and it lets you know how, when they're inserting it, how we can see where we are based on the waveforms. So here we're in the right atria, and it's just plugging along. Here we get into the right ventricle, the pressures are higher. What it's not showing you here is all the ectopia causes while it's in there, that everyone's like, ah, okay, settle down, ventricle. And then it's got to turn the corner, which looks so easy here and is not. It's got to be very careful going through this valve, and then comes up here to your pulmonary artery. When we do a wedge, here it is in your pulmonary artery. It's reflecting the systolic, diastolic, you can see it. But when we wedge, here it dampens down like this because there's none of that blood flow behind it. So there's a scale on the side of your graph that will tell you what that reading is. It gives you an average, and then you undo that balloon and let the blood flow again. And we get our reading that way. Okay, complications. Well, ventricular arrhythmias are a big one. On insertion, on removal, migration of the catheter happens. They can put the catheter in. They think it's in a good spot. They get a good wedge. They think everything's fine. They suture it down to where they inserted it. They connect all the lines up, and you can't get a good reading with a wedge or without. So it's probably caught in a side tributary somewhere. They have to come back in, pull it out a little, push it in a little, whatever they can do, manipulate the catheter some. If they can't get it to a point, you know, now it's anatomy by Braille. They're essentially fishing around in there. If they can't get it to where it's giving us good, reliable readings, then they'll tell you we can use it for fluid, but not go by the readings to do any adjustments. And that's too bad. That person has gone through the risk and the expense of having a Swan in, and it's not giving us readings. So infection, definitely sepsis. This would give them an infective endocarditis in a heartbeat. So be very, very careful. Everything is changed by policy. Tubing, stopcocks, everything is changed by policy. The bag, it takes a while for, if you're just waiting for this to run out of fluid at 3 mils an hour, it's gonna be a long time. You don't leave a dead bag up there. Take it down. We change them and they're not even half empty. You know, depending on the policy in your hospital, you got to take them down and change the whole thing out. Okay, air emboli are always a possibility. Air in the line. We prime everything. If you prime everything for a regular IV before it goes in a peripheral site, imagine what we're doing for central lines. All the stopcock sites are flushed out, everything, so that there's not a little gap of air inside a stopcock. I mean, everything is primed to the T before it's hooked up to a patient. So you have to be careful. Pulmonary infarct can happen. If the wedge is held too long, you can infarct the pulmonary system. It can rupture. People that have that tenuous vasculature can rupture just by inflating the balloon. So since we can do the apical pressure, cardiac outputs and all that, they use it less. They use it only if they absolutely need it for other things. Okay. What else? Central venous pressure, it's the same concept underneath, all the same thing. What we're getting is central venous pressure, which is the same thing as right atrial pressure. Central venous pressure we're catching as it's coming from that inferior to superior vena cava into your atrium. It's the exact same pressure. It's giving us an idea of what the right ventricle is full of, what the pressure is after diastole. If we could stop the heart dead at diastole and measure the pressure, that's the indication it's giving us. It's telling us a lot about someone's general fluid volume status. If they have a lot of fluid on board coming into the heart, if they have less fluid on board coming into the heart. It can be done with just a CVP line. Excuse me, so they put a central line in and it's right into the inside of your right atria. They could hook that up to a manometer system and just measure off of that, and they're going to get a CVP pressure. And they do sometimes, those that you sometimes see on the floors. But it can also be done through the proximal lumen of the Swan-Ganz, the proximal one, the one that is closest to the origin of the line. So that's up by the atria. So we can catch it there too. So more than one way to measure these things. So normal values, I said 2 to 6 is your ballpark. So a low CVP is telling you your patient is dehydrated. It's your gunshot wound in, that's just bleeding out all over the place. It's someone who's been on a nitroglycerin drip and they're systemically vasodilated. All of that is going to contribute to your low CVP. Makes sense, right? Okay, increased CVP, your pressure is high. Maybe you're hypervolemic. Maybe you've had fluid resuscitation in the ED and a trauma code, 100, they keep hanging the bags and you're getting hundreds of mils of fluid. Maybe it's vasoconstriction. Is your patient on one of those vasopressors that's clamping down all the circulation? So the pooling, the circulating of blood is in a much smaller area, which will raise your CVP. Pulmonary hypertension, you have pulmonary issues and you have pulmonary hypertension. If we're taking a reading from just inside the heart, it's going to reflect that. Right-sided heart failure. You're one of these people, we don't see it much in adults, but if you have right-sided heart failure and that's your issue, it's going to be reflected in the pressure that's measuring your right ventricular diastolic pressure. So it's pretty simple, what causes it to go up and go down. But the information is useful when someone's in critical condition. All right, so venous set monitoring, I mentioned that a little bit. We're looking at how this mixed venous blood, think about it a minute. If you have pumped out blood into the system, it's full, basically this slide is telling you, it's full of oxygen, as full as it's gonna get when it leaves the heart. And it goes out into the body, right? And it's been out and provided the periphery and all the organs, everything it needs. And now it's coming back. So it can mean that your patient's improving. If you have higher SvO2 levels and we're measuring those, we're saying, all right, on the venous side, the O2 is up some. So it could be the patient's improving. They're getting more oxygen in the system. It could mean they're septic. Now, why is this? Because in a septic situation, the body can't utilize oxygen. So we may think, well, we've been giving them oxygen, we've been doing this and this and this to support them hemodynamically, so now they have a higher SvO2, good for them, they're doing better. Or are they septic? Were they infectious to begin with, and now they're septic? And now we're providing this oxygen to them, but the cells can't utilize it. So it's coming back in the venous system and it's at a higher level because it's not been utilized. So that's a big dichotomy. It's either, yes, your patient's improving, but if they're an infected patient that you're worried about sepsis, they could be septic. It's not always a good sign. Okay, enough about SvO2. So here's your multiple lines, all right? These are only 3. When you're in the ICU, if you go up there to visit, to precept, I don't know what we're gonna have. I don't know where we'll be. We might all be on the same floor, I have no idea. But if you see this, you're gonna see even more monitor strips than this. And so here's your heart at the top. And this, oh look, this patient's in AFib. So here's this patient over here with the EKG. Here's the arterial pressure. Here's your dicrotic notch we talk about. And you see how there's a spike here for ventricular beat. We see it reflected here. And there's another one here, and we see it reflected right under it. And another one here and right under it. So if this patient up here would have a PVC, it usually doesn't perfuse. So, because it's not full of enough blood, it's coming premature before the ventricle is filled, right? So we'll see it on an EKG. So you'll see this big inverted ugly PVC and you see nothing here. So anyway, it's interesting, but that's how it goes. So that's your arterial line. Your CVP would be right under it. Now we can do your temperature under there. We can do your O2 sats under there. We can monitor everything in a single shot. So that's what's so helpful. And, you know, you work in that area, you need information all the time at your fingertips. And provided you are maintaining adequate equipment and it's accurate, you can go by what you see for your numbers. So that's important. Okay, what else? So what do you do with hemodynamics? Assess your patients. You know how sick these people are. Assess them often. Be thorough about it. Don't say, well, they moved him. Was he moved that much? He looks like he's in the same spot. You can't be shoddy with this stuff. You can't be. You have to be laser focused. Maintain the equipment. Make sure your readings are accurate before you touch a dial. I've had people whose lines have been disconnected, called into a room and the line isn't even connected or something, and they're bleeding into the bed. No one sees it. The hand is under the cover. And they're looking up and they're like, wow, look at this BP. I better go up on something. And the patient's sitting up, eyes open, looking at me. I'm like, this is not the picture of a patient with no blood pressure. I mean, what's happening here, you know? So you look at your patient. I mean, if they're sitting back reading the paper, unlikely in an ICU if they are on this equipment, but if they're sitting up reading the paper, I'm going to start head down and look at everything. Where's my equipment? What's my line doing? Everything hooked up? Is my bag at 300? Is everything opened? You know, look at my patient. He's looking at me. He's breathing. He's doing whatever. And then I check everything. And it could be your equipment. Your connections aren't tight. It could be anywhere along the line of that equipment. So equipment does become an important focus because we're relying on the numbers to change meds. And the meds are dangerous, dangerous. Okay, so don't forget there's a patient underneath there. Talk to your patients. I can't tell you the number of people that have come to and told me everything I've told them. It's like they feel they know me because I talk to them so much. So don't forget to talk to them. They're under there. Imagine how you would feel if you could hear what's going on. Your eyes aren't open. You're not moving much. You feel like death. How would you feel in that place? You know, you need to know somebody's there. Okay, why don't you take your lunch? What time is it? Yeah, and go take your lunch and we'll come back afterwards and we'll do aneurysms. You are almost done. Did I mention you are almost done? You're almost done. How exciting.
Hey, Jane.
Yeah.
Can I